Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we will be discussing anemias, red blood cell morphology and approach to diagnosis. Anemia originates from the Greek word anemia, which means without blood. When there is a reduction in the number of red blood cells or hemoglobin concentration, can lead to diminished oxygen delivery to the tissues, which can cause tissue hypoxia. Anemia is functionally defined as a reduction in the blood's capacity to carry oxygen, which can result from inadequate hemoglobin levels or impaired hemoglobin function. The former is the more commonly observed cause of anemia. In operational terms, anemia is defined by a reduction in the blood's hemoglobin content, which can arise due to a decrease in red blood cells, hemoglobin, and hematocrit below the reference range for individuals of comparable age, sex, and race, in similar environmental conditions. Patient history and clinical findings. In making a clinical diagnosis of anemia, the history and physical examination are crucial components. A reduction in oxygen delivery to the tissues decreases the energy available for day-to-day activities, leading to classic symptoms such as fatigue and shortness of breath. To identify the cause of a patient's anemia, a good history must be obtained, which requires careful questioning regarding the patient's diet, drug use, chemical exposure, occupation, hobbies, travel, bleeding history, race or ethnic group, family history of disease, neurologic symptoms, prior medication, previous jaundice episodes, and underlying disease processes that result in anemia. Therefore, a thorough discussion is required to identify any potential cause of the anemia. Certain features must be closely evaluated during the physical examination to provide clues to hematologic disorders, such as the skin for petechiae, the eyes for pallor, jaundice, and hemorrhage, and the mouth for mucosal bleeding. The examination should also check for sternal tenderness, lymphadenopathy, cardiac murmurs, splenomegaly, and hepatomegaly. Jaundice is an important indicator of anemia because it may be due to increased RBC destruction, which suggests a hemolytic component to the anemia. Vital signs must also be measured as it is a crucial component of the physical evaluation. Patients who experience a rapid fall in hemoglobin concentration typically have a fast heart rate, whereas if the anemia is long-standing, the heart rate may be normal due to the body's ability to compensate for the anemia. Moderate anemias, hemoglobin concentration of 7 to 10 grams per deciliters, may cause pallor of the conjunctivae and nail beds but may not produce clinical symptoms if the onset of anemia is slow. However, depending on the patient's age and cardiovascular state, symptoms such as dyspnea, vertigo, headache, muscle weakness, and lethargy can occur. Severe anemias, hemoglobin concentration of less than 7 grams per deciliters, typically produce tachycardia, hypotension, and other symptoms of volume loss, in addition to the symptoms listed earlier. Thus, the severity of anemia is determined by the degree of reduction in hemoglobin, cardiopulmonary adaptation, and the rapidity of progression of the anemia. Physiologic adaptations. When anemia is caused by acute blood loss, such as severe bleeding, it can trigger significant physiological changes to maintain adequate perfusion of vital organs and preserve homeostasis. In severe cases of blood loss, such as with trauma, the decreased blood volume and resulting hypotension can reduce blood supply to the heart and brain. As an immediate response, sympathetic overdrive occurs, leading to increased heart and respiratory rates and cardiac output. The body will preferentially divert blood to vital organs such as the brain, muscle, and heart to ensure oxygen is supplied to these organs even with reduced oxygen carrying capacity. Tissue hypoxia can also trigger the body to produce more RBC2/3 bisphosphoglycerate, which helps shift the oxygen dissociation curve to the right, increasing oxygen delivery to tissues. This adaptation is significant in chronic anemias as it allows individuals to remain asymptomatic despite low hemoglobin levels. With persistent and severe anemia, however, the strain on the heart can ultimately result in cardiac failure. Reduced delivery of oxygen to tissues caused by reduced hemoglobin concentration can also trigger an increase in erythropoietin secretion by the kidneys, stimulating RBC production in the bone marrow, and releasing more RBCs into circulation. It's important to note that with rapid blood loss, the hemoglobin and hematocrit levels may remain initially unchanged due to the balanced loss of plasma and cells. However, as blood volume is compensated for by the movement of fluid from the extravascular to the intravascular compartment, or by resuscitation fluid administration, RBCs become diluted, resulting in anemia. Mechanisms of anemia. The lifespan of a red blood cell, RBC, is about 120 days. In a healthy individual without anemia, approximately 1% of RBCs are removed from circulation due to senescence each day, and new RBCs are continuously produced by the bone marrow. Adequate RBC production requires several nutritional factors and normal globin synthesis. Excessive bleeding or hemolysis can lead to increased RBC loss and require the bone marrow to increase RBC production. Ineffective erythropoiesis occurs when the bone marrow produces defective erythroid precursor cells that often undergo apoptosis before maturing to the respiratory stage and being released into the peripheral circulation. This is seen in certain conditions such as megaloblastic anemia, thalassemia, and sideroblastic anemia. Insufficient erythropoiesis refers to a decrease in the number of erythroid precursors in the bone marrow, leading to decreased RBC production and anemia. Factors contributing to insufficient erythropoiesis include iron deficiency, deficiency of erythropoietin, which can occur with renal disease, loss of erythroid precursors due to autoimmune reactions or infections, and infiltration of the bone marrow with granulomas or malignant cells. Laboratory diagnosis of anemia. Many tests can be done to diagnose and evaluate anemia as complete blood count with red blood cell indices, reticulocytes count, peripheral blood film examination, and bone marrow examination. To diagnose anemia, medical laboratory professionals use automated hematology analyzers to perform a complete blood count, CBC, which includes measuring RBC count, hemoglobin concentration, hematocrit, RBC indices, white blood cell count, and platelet count. RBC indices such as mean cell volume, MCV, mean cell hemoglobin, MCH, and mean cell hemoglobin concentration, MCHC, are important, with MCV being the most crucial. An abnormal MCV can indicate microcytosis, a population of smaller cells, or macrocytosis, a larger cell population, and a higher red cell distribution width, RDW, can suggest anisocytosis. The RDW is calculated by dividing the standard deviation of the RBC volume by the MCV and multiplying by 100 to convert to a percentage. A reticulocytes count is also necessary for every patient with anemia, and the RBC histogram complements the peripheral blood film examination in identifying variable RBC populations. Reticulocytes count. The count of reticulocytes is a valuable tool for evaluating the bone marrow's capacity to produce red blood cells, RBCs, in response to anemia. Reticulocytes are immature RBCs that lack a nucleus but contain RNA to complete the production of hemoglobin. They typically circulate in the bloodstream for only 1 day while maturing. The reference range for reticulocytes count is expressed as a percentage of the total RBC count, which is 0.5% to 2.5% for adults and 1.5% to 6.0% for newborns. An absolute reticulocytes count is obtained by multiplying the percentage of reticulocytes by the RBC count. However, relying solely on the percentage of reticulocytes to assess RBC production may be inadequate, particularly in severe anemia cases. To obtain a more accurate representation of RBC production, the reticulocytes count needs to be corrected by multiplying the reticulocytes percentage by the patient's hematocrit and dividing the result by 45, the average normal hematocrit. In addition, the reticulocytes production index, RPI, is calculated by dividing the corrected reticulocytes count by the maturation time if reticulocytes remain in the circulation for longer than 1 day. The RPI is a better indicator of the rate of RBC production than the corrected reticulocytes count alone. Analyzing the reticulocytes count is critical in determining whether anemia is due to a defect in RBC production or premature hemolysis and shortened survival defect. Shortened RBC survival increases RBC production, leading to increased reticulocytes count, which is characteristic of hemolytic anemia but can also be observed in acute blood loss over time. However, chronic blood loss leads to iron deficiency and a subsequent low reticulocytes count. An inappropriately low reticulocytes count occurs when there is a decrease in the production of normal RBCs due to insufficient or ineffective erythropoiesis. Peripheral blood film examination. Examining the peripheral blood film is a crucial step in evaluating anemia, as it allows for an assessment of the size, shape, color, and inclusions present in red blood cells, RBCs. This examination also serves as a quality control measure to confirm the accuracy of automated analyzer results. Normally, RBCs are uniform in size and range from 6 to 8 mm in diameter on a right-stained blood film. Microcytic cells are smaller than 6 mm, while macrocytic cells are larger than 8 mm. Only by analyzing the RBCs on a peripheral blood film can certain shape abnormalities of diagnostic significance, such as sickle cells, spherocytes, schistocytes, and ovomacrocytes, and RBC inclusions, such as malarial parasites, basophilic stippling, and Howell-Jolly bodies, be detected additionally. Examining the white blood cells and platelets can reveal a more general bone marrow problem contributing to the anemia, such as hypersegmented neutrophils in cases of vitamin B12 or folate deficiency, or blast cells and decreased platelets as a sign of acute leukemia. Bone marrow examination. When investigating the cause of anemia, a combination of medical history, physical examination, and peripheral blood tests are often sufficient. However, when the cause of anemia is unclear or the differential diagnosis is wide, a bone marrow aspiration and biopsy may be necessary to determine the underlying cause. This procedure is particularly recommended for patients with unexplained anemia with or without other blood cell deficiencies, fever of unknown origin, or suspected hematologic malignancy. A bone marrow examination can evaluate hematopoiesis and detect abnormal cell infiltration into the bone marrow. Various findings in the bone marrow, such as abnormal cellularity, ineffective erythropoiesis, and megaloblastic changes, may indicate the underlying cause of anemia. In addition, iron stains of the bone marrow can detect the lack of iron, while the presence of granulomas, fibrosis, infectious agents, and tumor cells can suggest abnormalities that may inhibit normal erythropoiesis. Immunophenotyping of membrane antigens by flow cytometry, cytogenetic studies, and molecular analysis are other tests that can be conducted on the bone marrow sample to further assist in the diagnosis of anemia. Other laboratory tests. Laboratory tests can help determine the cause of anemia, including routine urinalysis with microscopic examination, stool analysis, and chemistry studies such as serum haptoglobin, lactate dehydrogenase, and unconjugated bilirubin. In addition, serum vitamin B12 and serum folate assays are useful for investigating macrocytic anemia, while a direct antiglobulin test can differentiate autoimmune hemolytic anemia from other causes. Iron studies are valuable when a microcytic anemia is present, and a reticulocytes count and MCV can also help classify anemia. In some cases, rare deficiencies like insufficient copper due to gastric bypass surgery can cause anemia. Please don't forget to subscribe to our channel, activate notifications to get our new videos. If you like our content, please press the like button, and share the video with your friends. If you have any questions, leave a comment below. Approach to evaluating anemias. Anemia can be classified based on mean cell volume, reticulocytes count, red blood cell distribution width, RDW, and the underlying mechanism. First we will talk about the classification of anemia based on mean cell volume. The categorization of anemia based on mean cell volume, MCV, is essential for its morphologic classification. An MCV of less than 80 femtoliters with small red blood cells, RBCs, indicates microcytic anemia, which is often linked with hypochromia and a decreased MCHC. Microcytic anemias result from reduced hemoglobin synthesis, caused by iron deficiency, iron sequestration, defective protoporphyrin synthesis, thalassemia, or hemoglobin E disease. Macrocytic anemia, on the other hand, is characterized by an MCV greater than 100 femtoliters with large RBCs, caused by megaloblastic or non-megaloblastic red cell development. Megaloblastic anemias result from impaired DNA synthesis due to vitamin B12 and folate deficiency or myelodysplasia. Non-megaloblastic forms of macrocytic anemias are related to membrane changes caused by chronic liver disease, alcohol abuse, and bone marrow failure. Normocytic anemia is characterized by an MCV in the range of 80 to 100 femtoliters and is caused by premature destruction and shortened survival of RBCs or a decreased production of RBCs. A dimorphic population of microcytes and macrocytes must be ruled out to diagnose normocytic anemia accurately. Next we have the classification of anemias based on morphology and reticulocytes count. Involves using the absolute reticulocytes count to differentiate between decreased or ineffective red blood cell production and excessive RBC loss. In cases where the reticulocytes count is low, the morphological classification can further categorize the anemia into normocytic, microcytic, and macrocytic anemias. The category of excessive RBC loss encompasses acute hemorrhage and hemolytic anemias with shortened RBC survival. Then we have the classification of red blood cells based on their morphology and the measurement of the red blood cell distribution width, RDW. Can aid in identifying the underlying cause of anemia. By combining the RDW with the mean corpuscular volume, MCV, which falls under three categories, normocytic, microcytic, and macrocytic, the RDW can further classify each MCV group as homogeneous, normal RDW, or heterogeneous, increased or high RDW, as suggested by Bessman and colleagues. For instance, when the MCV is decreased but the RDW is increased, it could indicate iron deficiency. However, this classification is not always definitive since there may be overlapping RDW values among certain conditions within each MCV category. When classifying anemias based on their underlying mechanisms, conditions that share a similar cause of anemia are grouped together. This pathophysiologic classification system separates anemias caused by decreased red blood cell production, such as DNA synthesis disorders and aplastic anemia, from anemias caused by increased destruction of red blood cells, intrinsic and extrinsic abnormalities, or blood loss, which typically have higher respiratory counts. Some anemias can have multiple underlying mechanisms. Thank you for completing the video. Remember to ask for ASCP short notes, and don't forget to subscribe. Bye.